But, let's make sure that the community-wide dialogue doesn't end here, right? It shouldn't end here. Should you all determine a need for follow-up town hall, or perhaps specific training content relating to today's subject matter, let's talk about that. The North Star Center really is a resource, and one that aligns well with that united theme that we hear in United Ways, right? We talk about how we live united, we work united, and we give united. So how about we all kind of learn united, and united we address community issues no matter how complex. So thank you again for being here. It's my privilege to welcome and introduce Pat Fontana. He's the Director of Population Health for Fort Drum Regional Health Planning Organization, otherwise known as FDR-HPO. And they're not only a community partner, probably to just about every entity on the call today, as well as the United Way, but they also have a regional presence and are well known for facilitating collaborations around initiatives relating to health and wellness and social determinants of health. So welcome, Pat. The Zoom floor is yours.
Dawn, thank you. And thank you, Allison and Tanya, also for helping to put this together. And, of course, special thank you to our three panelists, each of them serving their respective counties as Director of Community Services or DCS. For those of you unfamiliar with their role, Director of Community Services, they essentially oversee the county's network of mental health, developmental disability, substance use services. And that includes service facilities, treatment of patients, among other responsibilities. It's safe to say that being a DCS anywhere in New York State is challenging. It has its challenges, but in a rural community, in a rural county, there are unique challenges that urban areas just don't generally face, at least not to the same extent. There are contributing factors in rural areas that just exacerbate the effects or the impacts of an existing illness or disorder, the things that we're going to be talking about today. In general, there isn't always from year to year a stark difference in the rates of mental illness and substance use disorder between rural and urban areas. So, why highlight the distinction then? Well, it's not really because the rates are necessarily starkly different. It's because rural communities, and many of you know this more than I do, they're disproportionately more severely impacted by these illnesses and issues compared to urban areas. And that's really due to factors and circumstances that are just inherent for rural communities. Think about things like geographic accessibility, transportation barriers, availability of resources, provider shortages, and greater stigma too. Everybody knows everybody in a rural community, and everybody knows everybody's business in a rural community too. It's this, whatever you want to call it, I guess an absence of anonymity, I suppose, that's also a contributor to that stigma. There's not that anonymity that an urban center would have. And now put a pandemic into the mix, and then things get a lot more complicated. So yeah, mental illness, substance use disorders impact all areas, big and small, but rural communities really feel the impact quite a bit more. So in turn, service providers are required to do more with less, to develop unique solutions and rely on each other, rely on neighboring counties. And that's really why we're here today with our three directors of community service who have done just that. They're going to provide us today with an overview of the status of their respective counties, insight into current issues, and answer any of your questions that you put in the Q&A. So again, we have with us today Tim Rutten, DCS for Jefferson County, Pat Fralick, DCS for Lewis County, and Jay Ulrich, DCS for St. Lawrence County. Each of them will take about 15 minutes or so, I think, to provide us with an overview of their county, the issues they're addressing, and the services they provide. And again, throughout the event, as Don said, you're welcome to post questions right in the Q&A section. It's at the bottom of your Zoom screen. So if your questions are intended for a specific DCS then also just specify who the question is intended for. If it's intended for anyone, then you can leave that blank. So I'll present those questions to them once you put them in the Q&A, and why don't we get started? And I think we'll go in alphabetical order. We'll go in the county's alphabetical order. So Tim, if you don't mind, if we start out with you to give a brief overview of Jefferson County.
You bet. Thanks. And I received a few text messages asking if the participants are able to be seen or heard on this. And the way this is set up, it's just the panelists that are that have their cameras activated. So, okay. So yeah, my name is Tim Rutten. I've been the Director of Community Services here in Jefferson County for approximately 3.5 years. I've been with Jefferson County in a couple of different roles for approximately 10 years. A huge thanks to Dawn and her team for putting on this event. It's not often that Pat Fralick, myself, and Jay get together to kind of talk in this way. We collaborate constantly behind the scenes, but it's nice to be able to do this as a group in public, have that opportunity. So thanks to all of you. I don't know if people have looked at the slide decks on the Padlet. Mine is by far the shortest PowerPoint, so I win that competition, and you are welcome. So I will share here. All right, see the slides?
No, not yet.
Oh, boy.
I told you, even when we practice, it doesn't work all the time, but
Yeah.
it's okay.
I'm absolutely doing my best. Okay. How about now?
There we go.
Yeah, we see it. Yeah, I think just open it up in the whatever the. It looks like it's in a different format now.
I'll get it off my.
Yeah.
Oh my goodness.
No worries. No worries.
I got it. Hold on.
I feel like technology is a universal equalizer. So no matter how tech savvy you are, the tech will humble you. So you can never be too confident. And while you're pulling up, Tim, I just wanted to share, it looks like Allison got the chat working. Thank you, Allison. When we get to Q&A, we'll be able to, if you raise your hand using the little icon on the bottom, we'll be able to unmute you if you'd prefer to ask your question verbally versus in the Q&A.
Okay, there we go.
Thanks, Tim. You give us a little interlude so I can fill in those logistics. So.
Yeah. Okay, now I'll try it again.
Perfect.
All right. Sorry about that. All right. So what do? I want to just take a minute to go over what the community services directors are responsible for in general. When you first become a DCS, one of the first things you're told is when you've seen one county, you've seen exactly one county. We are all very different in the pace, the tone, the perspectives. However, we all are under mental hygiene law, which outlines what our specific duties and powers and regulations are. So the offices of community services exist in every county. We're established under mental hygiene law. And we're appointed either by the legislature or by the community services board, depending on how the county is set up. And then the final approval for a DCS is made by the commissioners of OMH, OASIS, and OPWDD. There's specific criteria for DCSs, and it's all kind of laid out in the mental hygiene law pretty specifically. So if you ever are interested, take a look. We're responsible for developing the system of local behavioral health services under those 3 agencies. We are responsible for establishing the long-range goals of the behavioral health system, and we do that in what's called the annual service plan. It generally is a pretty comprehensive layout of what our challenges are in the county and what we want to do about it. Since COVID, it's been really reduced to more of COVID related surveys and questionnaires. I think it sounds like next year, a brand new large comprehensive plan template is going to be introduced. So we'll get back into more of a normal planning session. Generally, community services boards and communities are engaged in that planning. We serve as a center of promotion of community and public understanding of the local system of care. That's really how we're positioned as the local government unit in a county. We are the ones that generally have our finger on the pulse of all things behavioral health. We are responsible for making policy and for exercising general supervisory authority of local services and facilities. And we either provide or contract for the provision with local agencies for mental health, addiction, and intellectual developmental disabilities. So as I was putting this presentation together last week, I was going through a bunch of statistics that really indicated and showed clearly the increase in behavioral health issues over the past few years, especially with regard to COVID. And you're more than welcome to take a look at this slide and go through those numbers. They're important, there's no doubt about it. But there's a number that came up yesterday that I think encompasses all of this, and that number is 24. So yesterday afternoon, I was at an event with a colleague, an exciting event that I'll actually talk about in a few minutes, and her phone was ringing and ringing and ringing, and after she got a chance to put her phone away and take a breath, she said, "We're at 24 and the Capital District is full." And so the significance of that number is that she was talking about the amount of behavioral health emergency patients that were at our hospital in the emergency department. This is an emergency department that has 4 designated behavioral health beds. And we were at 6 times that amount yesterday afternoon. I'm not sure where it is actually today. So it's 6 times the amount of patients. That requires a tremendous amount of additional staffing. It requires more oversight, and it's not the best type of care that can be provided. There has to be an outlet on that number. People coming in the front door, we need to be able to put them into the proper treatment and safe place. And the second part of her statement was that the capital region was full. That means that all of the hospitals that would typically be able to receive these patients from Jefferson County to provide them with the correct treatment and supervision, they were also full. So it's not us. It's not just us. It's all across the state. This is a nationwide issue. We're all busting at the seams. And that's why I think that number really is important to take away from this. And while was 24 of these patients, that doesn't even begin to explain how many people didn't make it to the emergency room yesterday for various reasons, or they didn't have a phone, or they didn't have someone to help them make that call. Whether it was, they were too ill to seek help or to be able to seek help. That number is far greater, and it really drives home what we're going to talk about as far as the services that we need and the services that we're going to be putting into place that are currently in the pipeline. we have a need for increased crisis services. That number at the emergency room shows us where we're missing. We're gapped in that type of service. We have to enhance what we currently have. We have to make sure that access to these services don't have obstacles in front of them. We need to really ease that access wherever possible. And we need to be innovative. We need to really target the emerging needs and address our existing needs in new ways. That's just imperative, and that's all counties have to do that. This is where we see the intersection between behavioral health and social determinants such as homelessness. It's impossible or nearly impossible to get well, to stay in recovery, if you don't have a safe and secure place to sleep or as a base of operations. And over the past couple of years, those two issues, behavioral health and homelessness, have really intersected in our community and become issues that have to be solved and worked on together. So over the next months and actually a couple of years, we have a lot of great opportunities coming along. We're in a weird spot in the behavioral health field in that there is money available that was never available before, much of it as a result of COVID. But there's also a lack of workforce. So even when we have money or the resources to build capacity, we often lack the ability to staff those positions. So we solve one problem, we end up with another. But through, again, some innovative practices, through more creative recruiting strategies, we're really hopeful that these programs will be online as quickly as possible. I'll start with youth and adult mental health respite beds under the 589 regulations. We currently in Jefferson County have therapeutic crisis respite program for adolescents that allows young people who are having a mental health crisis, who don't necessarily meet criteria for hospitalization, but do not have a safe environment to return to at home. They can stay in this program for up to 2 weeks and receive aftercare programming, family counseling, intensive family counseling as a result. We're adding adult beds, similar model, and they're all going to be under 589 regulations, which is going to hopefully provide a more robust funding stream for that youth program. So that's an exciting change that's coming. ACT, so Assertive Community Treatment Team here in Jefferson and Lewis counties. It's a huge win for our community to be awarded the ACT award. It's a multidisciplinary clinical team who will be focused on wrapping services around our most complex cases and people in need. It really is a key component in helping people avoid hospitalization and the emergency room. We'll be able to provide the care that's needed prior to them entering crisis. CIT training, so is for law enforcement. It's a 40-hour training. Crisis intervention team is what it stands for. Jay is going to be talking, I think, in more detail about CIT, but we'll be doing CIT here in Jefferson County in 2023. We just started mobile access program here in Jefferson, and that is a virtual version of crisis services that allows law enforcement to have a cellular enabled iPad so they can have instant access to crisis specialists. We had yesterday, I mentioned I was at an event that was the the groundbreaking for the new behavioral health urgent care that's going to be located on State Street. That is a concept. We started talking probably 10 years ago about the need for a third option to the emergency room and to jail. Well, since that conversation happened, bail reform removed jail as one of the options for law enforcement when they have a person in severe behavioral distress or emotional distress. The behavioral health urgent care is going to be able to provide a vast array of services, both mental health and addiction related, and it's going to be all day, all night. When a person needs help at 2 a.m, they shouldn't have to wait until 9 o'clock in the morning to make the phone call to a clinic. This will allow instant access to stabilization. We actually toured a stabilization center in Dutchess County about 5 or 6 years ago. Loved the concept, but it was simply too expensive and outside of our scope at the time. We're very excited to see this coming to Watertown and Jefferson County. St. Lawrence just opened theirs up a few months ago. It's a great addition to our services. We're going to be looking at enhancing crisis services overall. Jefferson County currently does not have an actual mobile response team. We do follow-up work. We have a crisis worker who's fantastic, but his primary goal isn't to respond to crisis. It's really more of a follow-up system. We are currently exploring getting back to a mobile crisis response team, seeing what models would work the best for our community, whether that is a standalone team or whether it's behavioral health clinicians that are embedded with law enforcement. We're really going to have to see. And we're also talking about, as we build this enhanced program, is it something that can be done across county lines? We share so many clients. We share almost all of our agencies across over into the 3 different counties. It makes sense to really think about systems like crisis response from a 3-county perspective whenever possible. One of the big changes and challenges that we've faced over the past year is the new legislation that requires substance use disorder services within all jails and prisons in New York State. It's an important piece, and it's an important thing that we hadn't been really good at in New York State for a bunch of reasons. Regardless of that, the legislation is there. In October, we're going to have what amounts to a miniature substance abuse clinic within the jail. And that's going to include the availability of medication-assisted therapies. It's a heavy lift, from just simply making sure there's enough space to do it, to working through all of the regulations between OASIS and corrections law and the DEA laws regarding things like methadone and Suboxone. It's taken a lot of work and a lot of collaboration. I'm happy to say that we have made huge steps here in Jefferson County. And it's really come down to the jail personnel and our provider sitting down and getting through all of the tough questions and making it work. And we're almost there. We're very close to having a complete array of services there. So that's an exciting addition to the community. We've had some really great work done with collaboration between the behavioral health and the justice system. And this is outside of just law enforcement. One of the things that we realized over the past year or two was that a lot of people in the behavioral health system were also justice involved. And the justice system, including the courts, the district attorney's office, public defender's office, really needed to have a better understanding of how we do things in the community on the behavioral health side and what we can do as a resource to them. In Jefferson County, we've established a standing meeting between my office, DA's office, and the public defender's office to discuss those complex cases and make sure that behavioral health symptoms and behaviors are not criminalized. And where possible and where appropriate, those criminal involved behavioral health clients can receive treatment as opposed to incarceration or restoration services. That's a big win for all of us. I think it's a good use of collaborative time between county departments and amongst the fields. This office always, it's amazing how many public defenders and assistant district attorneys and probation officers come into the office to collaborate on cases. It's really exciting, and it's a good partnership between all of us. Obviously, we're here today talking about how behavioral health bumps into the homelessness piece. That's such an important thing to think about whenever we're looking at the addition or enhancement of services in behavioral health. How can we also make that work and assist and enhance those social determinants like homelessness? A project that's a little further out, but still just as exciting, is 60 permanent supported housing beds that will be coming to Jefferson County. 15 of those are designated as mental health, 15 as substance use disorder, and then 30 will be mixed use. Those are beds that will be taking people off the streets and from insecure housing and putting them into a place that gives them a base of operations to get better, to build a sustained level of recovery for themselves. So that's kind of in a nutshell where I'm at. I am not sure what I have for time.
I think you're right at the time limit. So you're good.
Okay, well, great. I feel pretty good about that.
Yeah, perfect timing. Yeah, Tim,
I appreciate everybody's time.
yeah, thank you. And just to recap some things, and please correct me if I'm wrong on any of this, but some takeaways here is that the stats that you showed, the alcohol consumption, the increase, the thoughts of suicide, which was staggering increase, stress levels, all in 2020, that's a pretty clear indicator that COVID has had some huge negative impact on Jefferson County. But it also looks like law enforcement is being called to assume a more prominent role really in assisting with crisis responses and with things like CIT and SUD services and jails and things like this. And the interesting thing is they're not targeted as punitive measures either, are they? They're efforts to really ensure the health and safety. So that's a great thing to see.
Yeah, it's important to really look at that, because one of the, and you talked about the difference between rural and urban. It's a lot different when you think about fielding a behavioral health response team in an urban area, as opposed to a place like Jefferson County or St. Lawrence County, New York, where you have blizzards and literally an hour in good weather, an hour drive or an hour and a half drive end to end. We already have law enforcement officers on the road. We already have them throughout our community. We need to be able to use them as effectively as possible and make sure they have the tools to get that job done in the best way possible.
Yeah, absolutely. And it looks like in Jefferson County that there are new resources in place or soon to be in place that allow for enhanced services to continue. So Tim, thanks very much.
You bet. Thank you.
So next we have Pat Fralick, DCS in Lewis County. So Pat, it's all yours.
So good morning still. Everybody can see my screen, I'm assuming?
Yes.
All right, perfect. All right, now let's see if I can advance it. Here we go. So Patrick and Tim shared a lot of information about the role of the Department of Community Services, the DCS. So I want to take a minute and kind of look at what Lewis County brings to the table. So you're looking at some statistics that I found online. But essentially, I really want to spend some time talking about how these aspects are important when you're looking at planning for services or, developing a needs assessment. So again, we talked about being rural. 13% of our population lives in poverty. We have a large geographic area with very few people on it. That clearly impacts access, transportation, and certainly getting your needs met. Ethnicities, we don't have a lot of diversity here. We do have a large Amish and Mennonite population. Those populations very rarely seek psychiatric or behavioral care. And then, again, the theme has been homelessness today. Now in 2019, 53 individuals were actually identified as being homeless. However, in Lewis County, the culture is people are related. And either you're related to people, large extended families, a lot of people are just kind of hanging out, at the invite of friends or family, but really could be considered homeless. We also have, in the whole time that I've been here, a significant high suicide rate for our population. And that has really kind of hovered at the same amount since I've been here. There we go. So I think that we can all agree that everybody speaks right now, either what's going on pre-COVID or post-COVID. So when we are looking at what was going on before the pandemic, Tim reflected the local services plan. The plan is based on what needs that you've identified, and not just community services. It is the service providers, county residents, kind of talk about what those needs are and what these barriers are to getting and accessing services. Housing has been identified for a very long time. Transportation, getting where you need to be, whether it is to address your health care, your physical health, even getting your goods, your food and all that kind of stuff. That has been a problem. Crisis services have never not been on the plan. And, Jim had alluded to the fact that there are some movement opportunities that, as a result of the federal funding, that we now have available and are in the process. Workforce was almost at a crisis level pre-COVID. And obviously, when you look at these areas, those are very, very important when you're trying to get somebody, or you're trying to get care and your care for your family. So let's see. Tim mentioned stigma, and we talked about being very rural. We talked about a county that really everyone knows everyone. And, if you are sitting at Prado on the number 3 road, people know who's driving that car. There is a lot of concern when I do surveys for the residents, or see surveys that are done by agencies. One of the highest areas that are reflected is I don't seek care because I don't want people to know that. And we don't necessarily have a lot of opportunities to ensure someone's anonymity. So that certainly is a challenge. I think the other side of this is, because everybody knows everybody, you typically can figure out a way to get your needs met. And sometimes not in the traditional picking up the phone and going to an appointment. So those both have, the good things and the bad things. Now, Tim talked a little bit about what it is the DCS does. Essentially that we are planners and conveners. He said that each county has a DCS. And I remember early on of a DCS saying that one of the things that she found surprising is the fact that the people, agencies, residents really feel that the DCS can really do more than they actually can. And that's why it is so very important that we develop and maintain relationships, not only with our county agencies, but any agencies that are addressing the social determinants of care, the law enforcement, the healthcare system, the school districts, because the areas that we're talking about play out in those areas. And when you're talking about solutions, you really need to understand and involve the other stakeholders in the group. So it's very, very important that those relationships and creating opportunities so that you can collaborate, you can get information. And then what then impacts that is when we have changes in leadership, when we have changes in the people that that you have worked so hard in incorporating or including them when you're talking about problems and solutions. I'm trying to pick and choose because Tim and Patrick kind of talked on so many of the areas. The other thing that Tim kind of talked about is the current situation of services and the new situations or circumstances are coming down the pike. And one of the things that New York State has been doing for many, many years is presenting opportunities on a regional level, meaning that this is the service, and this service and this provider serves 2 or 3 counties. And the reality is that, you know, it's all about location. Is the TCRP in Jefferson County, do they serve Lewis? Absolutely. However, the barrier of transportation or circumstances beyond controls keep that resident or potentially keep that resident from accessing those services. And, you know, again, that's why it's so important to either know the people that are providing it, making sure that the referral sources know who to call to help us facilitate that process. All right. After COVID. Again, the areas identified before have not gone away. However, the stress of the pandemic certainly increased our need. It exposed us or had people that had never been in the system before reaching out. We found that people really, despite everybody's efforts to making sure that services were known, we found that it was difficult for new people to access. A lot of time was spent in education, educating people, using social media, using other methods to be able to get the word out. We really, over time, really saw an increase in need of services for children. How the children were responding to the isolation, the disruption in school, working out of the home, how the parents were responding to either being unemployed or suddenly required to be the teacher for your children. It really, and it continues to be there. We continue to see and anticipate that the impact of the pandemic is going to continue to demonstrate it. Really, people identified the stigma of needing help, the isolation, and having to look at different methods to access care. People didn't want to talk about it. People didn't want to acknowledge that they had this need until it got to crisis level. And the impact on the services for the developmental disability, we were already in a jam for specialized services. And clearly aspects of containing the pandemic really impact our disability, developmental disability residents, because the isolation kept and had them not have opportunities to utilize and learn the things that were really helping them be successful in our community. So what I'm showing you now is the contract agencies that provide mental health, substance use disorder, and developmental disability services. Lewis County has one of, and by having such, not limited, but I want to say the basic services, we are challenged when someone needs an intensive level of care. Tim talked about the 24 people that were sitting in the emergency room yesterday. Samaritan Medical Center serves as a 939 hospital for Lewis County as well. Again, if you think about someone sitting in that emergency room, whether you're a child or adult, for sometimes days, if not weeks on end, as someone's trying to find you a bed, that is just not a great circumstances for anyone. And think about the family members that suddenly now have a family member in Albany for treatment. How does that family member support that person in their acute care needs or in their long-term recovery? We, despite being included in the additional services that Tim mentioned, it's extremely important that we are collaborating, communicating, and working as a team, because whether it is a treatment service that someone's receiving or a supportive service for heat, for food, it's very, very important that we're collaborating together so that if we can get person connected sooner, that we're having less need to access those high need services. In Lewis County, we have, a great participation by our agencies and our supporting partners in our community services board subcommittees. We have a priorities council so that we can keep everybody apprised of what's going on and where. Again, when you're talking about your strategic plans or your agency mission, reaching out to other providers to make sure that we're not, either missing a need and addressing it, or doing, double duty and offering the same service a couple times, because we don't have the workforce, we don't have the resources to be able to support that. The other thing that we're doing in Lewis County to address our needs is people might be familiar with the single point of access. That's a access point for all the counties to be able to address someone that has some urgent needs or high needs. Lewis County received a Office of Mental Health grant so that we can enhance our SPOA process with the systems of care philosophy. That's intended to not only ensure that we have a diverse team of providers that are trying to support our children and families in the SPOA or the SPOE world, but it's about incorporating and bringing in the school districts, law enforcement, the health services, and obviously engaging and encouraging the children and families to participate in their process and keeping them engaged. And then again, that is with the goal of intervening sooner. Because again, given the fact that we have so little inpatient resources or acute care resources, it is just really imperative that we all work together and, see opportunities where they are and being able to connect that or support that person, in services that we have, a little bit more of. So on the horizon, there was certainly some good things out of the pandemic. There had been some hesitancy in regards to how and what method a patient could access care. And clearly within almost, I think, 48 hours, it was expected that we all become Zoom, proficient and, being able to navigate, all the methods. I think that is a great outcome, for the field. And it certainly did assist people and keep them somewhat connected to their service providers. In Lewis County, we have areas where we don't have internet. So it isn't, the be all end all. And I think that we can all agree that having this as an option is important, but not everybody responds to telehealth for whatever reason. So, it's another tool in the toolbox, but I think that we just need to monitor and making sure that we're checking on outcomes and ensuring that the use of the telehealth is actually beneficial to our patient population. We talked a little bit about the importance of crisis services. Again, New York State is expecting people to receive care in their communities. And we've demonstrated that we don't have all the care in the care options in each community. So being effective and efficient. Tim indicated that, the ACT team is going to be a very valuable tool. It comes with it the need for a high level of staffing. And with our workforce crisis and being able to attract and retain qualified individuals, that certainly is going to have to be, it's going to be a challenge for the services provider that's going to do that. We've seen the importance and value of integrated care, meaning that a person can go get, not only their mental health care, but their substance use disorder care at the same time. There's certainly been mechanisms to not only address and coordinate the care there, but also address the medical needs of our client population. And, the world of peer services. Here's another opportunity to support someone as they enter this very, very high pressure and this very confusing sometimes continuum of care. Being able to access and support somebody, is just going to be able to help us, keep someone, I guess, engaged in their care. And I want to thank you. This was a great opportunity.
Thank you.
Stop.
Thanks, Pat. Thanks very much. A couple of interesting takeaways there. So before COVID, notice that your local services plan, your priority areas, I forgot exactly what they were, but transportation, crisis services, workforce, and housing, I think. After COVID, none of them went away.
No.
They still stayed there, but yet you were compelled to include additional areas of focus in prevention, stigma, developmental disabilities, and things like that. And that was during a time when workforce was struggling quite a bit. So that was kind of a double hit to Lewis County. And one thing that just resonated with me was when you were discussing children, when you were discussing youth. And I guess most of us probably can't kind of experience or fathom this, but not every kid wants to have a snow day. And think about some of those kids whose home situation is less than ideal. And COVID was a year and a half of a snow day essentially for them, and the trauma and the experiences that they had to go through. So I guess it's no surprise that additional services for that age group is needed. So that was just a quick takeaway that I noticed that I wanted to kind of bring up. So thanks again, Pat. Thanks very much. Next, we have Jay Ulrich from St. Lawrence County. So Jay, it's all yours.
All right, can everybody see my screen?
Yep, it's right in front of us. Yeah.
All right, thanks, Pat. And thanks for the United Way for putting this on. We certainly appreciate it. So I'm Jay Ulrich. I'm the Director of Community Services for St. Lawrence County. Before I get into my slide deck, I just wanted to, speak to some of the deficits and the gaps that we have here in St. Lawrence County. I've been the Director of Community Services for 5 years, be 5 years next month. And when I first came on board, we had 6 mental health clinics, and we had 5 addiction clinics. So since 2017, we increased those services. We now have 11 mental health clinics in the county, and we have 10 addiction clinics type services in the county. So, we've expanded quite a bit. I did a recent tally in terms of where the clinics were in terms of their capacity and to be able to take on new patients or same day appointments and things like that. So, with the exception of 1 or 2 of the clinics who were fortunate enough to recently hire new staff, all of those programs had waiting lists. So in spite of the expansion, we just can't seem to keep up with the need for behavioral health services in the county. And I think it's not just our county, it's probably statewide, and it might even be probably national because of the workforce shortage. So, I think we all would like to expand our services. There was one agency that said if they could, they'd hire 5 or 6 new mental health clinicians, but we're just having trouble, kind of finding folks that are available, for hire. So it makes it difficult. We do have mobile crisis. That is by Reach Out, and they provide mobile crisis from 9 a.m. in the morning to 11 at night. Now, there is the guidance, so to speak, from the O agencies that it should be 24/7. So that's something that we're hoping to move the needle on in the future. But that's tough. I mean, St. Lawrence County is the biggest county in New York State. So it's difficult to be able to, to travel and provide mobile crisis services, particularly in some of the outlying towns in the county. So probably not unlike other counties, we do continue to have high rates of behavioral health, emergency department events. Sometimes there's people having to wait in the emergency rooms for an inpatient bed if after evaluation they met that criteria. So that continues to be a deficit in terms of getting people the services that they need when they are in crisis. We don't have IDD, crisis respite, or crisis services yet in the northern part of northern New York, but they are working on trying to create a hub for IDD crisis services. So some of that hopefully will roll out in the next year or so. So in terms of our homeless population, there's been some growing concerns in the city of Ogdensburg about an increase in the homeless population. So recently, Step by Step and NERCL, the Northern Regional Council for Independent Living, are forming a work group and trying to come up with solutions for that. It's not to say there isn't some homeless populations in other parts of our county, but I think Ogdensburg, has a little more than some of the other population centers, within our county. So in terms of where we're trying to go, so St. Lawrence County recently opened up an opioid treatment program. A year or so ago, we applied for a Justice Department COSSIP grant when we received $900,000. So on July 18th, we opened up our opioid treatment program. Surprisingly, the first day we had people in our waiting room at 7 o'clock in the morning that were moving here from out of state that needed services. And since that time, we've been open for 3 weeks, and we currently have 31 OTP patients. And we anticipated having 30 at the end of the first quarter, and we have 30 at the end of 3 weeks. So certainly is a need for that. And, you know, we're fortunate enough to have gotten that grant and expand those services. So those are in Canton. They're at the Human Services Center, which lies just outside of the downtown district. So we anticipate eventually probably having over 100 patients, but you know, it's hard to say. But that was quite a lift in trying to get that off the ground. But we are up and running with that. Oops. So as Tim mentioned, there is a jail mandate across New York State, not only for county jails, but also for the state correctional facilities. In our county, we originally had $60,000 to provide forensic services in county jail. Because of the mandate, that state money increased to $160,000, but it's still a partially unfunded mandate. You know, it's really hard to project how much it's going to be, you know, costing, you know, the county, but it could be upwards to $200,000 once we, you know, fully implement the program. And they're wanting us to not only provide MAT services, but also peer services, groups, individual counseling, discharge planning, and you know, post-release services. So that, you know, we're working on that. We're in the middle of creating or have created policies for that. That's a work in progress. The county clinics are the forensic provider and have been the forensic provider for both mental health and addictions treatment in the county correctional facility. So back in, I believe it was April, Citizen Advocates opened up behavioral health urgent care in Augsburg. And this was on our local services plan for a number of years. So I just really am appreciative of Citizen Advocates stepping up and opening up what really turned out to be a very beautiful site. You know, they renovated the building entirely. So, you know, it is, hopefully it's going to provide some relief in the long run to the number of people going to the emergency rooms, that they can get diverted here for 24-hour, 24/7 crisis services. They are open on weekends, evenings, holidays. They have an open access line, a crisis line. And the services that they're providing are going to be crisis services, stabilization. They can do inductions of MAT, medicated assisted treatment, and provide ongoing care. They're also going to provide ongoing family, individual, and group counseling. They have peer services, care management, and they can do some of those services through the telehealth component. So step by step, applied for an eShy grant for the Lincoln School site in Augsburg. So at the end of this month, in August, they will be opening up 20 supported housing beds, which is badly needed. I mean, we have a wait list, I think around 80, but that's always changing. So it's permanent supported housing. So there's no max length of stay. They're going to have on-site support staff. The way it works with supported housing is, you know, it's 30% of whatever income the individual has. So they're also going to be providing like skill building, health and wellness, community integration, and just all around 24/7 support. So we're looking forward and excited about that opening up in Ogdensburg. So, not unlike, I guess, Jefferson County, we also applied for the Mobile Access Program grant. And as Tim said, the law enforcement, and for us, we're starting off with the County Sheriff's Department. They have the use of 4 iPads through the grant. So when they are in the field and they come across a situation where they fear it's behavioral health related, they can dial into the provider, which is Citizen Advocates, and through the use of a tablet and a telehealth platform, they can hand the individual that's in crisis the iPad, and the Citizen Advocates crisis staff will be able to do a in the field real-time evaluation, which would help to provide a disposition as to whether they need inpatient care, or whether they can go to the urgent care, or whether they just need to be connected to community-based services. So again, we're excited about that. The goals are to increase timely access to mental health, decrease unnecessary transports. It is a burden on the police to transport someone to our 939 hospital, which is Claxton. Sometimes they have to travel over an hour to get the individual to the hospital. And in many cases, sometimes the individual is released because they don't meet the criteria, and then they have to find transportation back to their home. So this will help with that. And then also just to connect the individual to community-based services, whether that's clinic services or care coordination, whatever is indicated. So I think I'm missing a slide. So we're also looking into, and we've started a work group to oh, I'm sorry. This is still on the MAP program. So they get verbal consent in the field. They contact the mental health via the iPad. The iPad is provided to the distressed individual, and then the evaluation is accomplished. So there is, a requirement of the grant afterwards. There's a brief questionnaire that is completed by both law enforcement and the mental health clinician. So we also received a grant for the crisis intervention program, and that's a collaboration between law enforcement, emergency responders, mental health providers, advocates in the field, consumers, county government, and others. And again, that also has an emphasis on diversion. So the 2 main goals of the CIT program are to transform the crisis response system to minimize the times of law enforcement's who are first responders. So we did what they call a mapping and sequential mapping in terms of instead of the police being the first responders, who might be available to try to meet the needs of the person in the community. But if that is not available, or that cannot happen, so when the police are the first responders, they have the knowledge and the skills to try to de-escalate the system, the situation. So the Sheriff's Department and other law enforcement agencies within the county are participating in this, and they will, for those who are participating, the officers that are participating, they will receive 40 hours of training. And part of the grant monies was to offset the overtime or the additional comp time needed for those officers to participate in the training. So that's going to be launched starting the end of this month and then into next month. So in terms of diverting, what we're trying to do is keep people out of the psychiatric emergency departments. So that would, possibly increase the volume to the Crisis Stabilization Center, which is Citizen Advocates, BHUC. There could be a mobile crisis team follow-up after the situation is de-escalated, could result in outpatient mental health appointments or addiction appointments, or possibly going to social services for housing and other support services. So we're also looking at a law enforcement mental health referral system, and this was created by Essex County, and it's been duplicated in some other counties as well. I think Clinton County is doing this right now. So this is an electronic referral system, and again, it's kind of real time in the field. If they come across a situation that has a behavioral health component, they can fill out a referral form on their device, typically a tablet. And there's a form that comes up for them, and they can fill in, this information here. The ones that are asterisked are required. If they have time, they can certainly answer some of these other questions. But once they complete the form, they hit send, and it will go to a designated community-based provider in the county. And then when they get that program reaches out to the individual the following day, or could be same day, and tries to connect them with community-based services, whether it be clinic services or could be rehab, it could be a lot of different services. So that's up and coming. We just started a work group for that. And then lastly, we are slated to get a mobile clinic delivered before September 29th. Now we've been waiting a year and a half for this because of the supply chain interruption due to COVID. So they promised that we're going to get this by the end of September. And we certainly are hoping so, because that's when the grant runs out, because this was grant funded as well. The one that we ordered was a 25-foot RV type of vehicle. It has 2 rooms. One's an examination room, but could also be used as a counseling room. And then there's the counseling room to provide individual services towards the front of the vehicle. It comes with use a handicap accessible entrance. It has a bathroom, has a sink, has a refrigerator for medications if indicated. So what we're thinking in terms of the use case for this, we've reached out, we did a survey monkey to some of the school districts, or all the school districts, and 6 of the districts had interest in us providing mobile clinic services to their students during the school time hours. We're also planning to try to target some of the remote areas in St. Lawrence County. It's likely that we're going to be probably using more municipal type parking lots rather than going to individuals' homes. So we're still working on the logistics of this, but we're hopefully going to be able to do both mental health and addictions treatments out of the van, and possibly even some public health services such as immunizations and so forth. So that is also coming down the pike. And I think that's all I have.
Okay, thank you, Jay. Thanks very much. So notice that you've greatly increased services the past couple of years, and you are leveraging technology very well, and which is important considering, like you said, St. Lawrence is, I don't know if it's the largest geographic county in New York State, but it's certainly the largest of the 3 that we have here. So it's very widespread, and folks that don't have access to that type of technology, or even before we had that type of technology, the traveling that people had to do was quite burdensome, it seems. So thank you very much. I think now it's time for us to go to our Q&A portion. And there are some questions here that I'm going to read off in a bit. I don't know, Tanya, can folks raise their hand for us to be able to see?
Yep, we won't be able to see them, but if folks would prefer to unmute, we can do that.
Okay, so they'll just speak up. Is that what you're hoping? Okay.
Yep.
So anyone that has a question and you want to verbally ask that question, feel free to just interrupt me as we go along. If not, I will start off by reading some of these questions that we already have here. So the first one is directed to Tim. So Tim, do you have a timeline when the 60 supported housing beds will be available to Jefferson County residents?
Yeah, actually, unfortunately, this is one of those projects that's further down the road. It's a big project, a lot of moving parts. And right now we have the award, and the agencies that are going to be doing the work are in the preliminary kind of stages of looking at a site, partnering with the community. We're really realistically looking at 2025
Okay.
for those beds to be open. And then the next question has to do with criteria for admission to those beds. The behavioral health 15 beds and the 15 for SUD, those will require clinical diagnosis to qualify for those particular slots. But keep in mind, this is a 60-bed project that has an additional 30 kind of mixed use beds. And that really frees up the criteria for use. On top of this, we're also looking at, we're going to be opening a single room occupancy program here in Watertown in the next month or two. And we're looking at all kinds of other options through the homelessness steering committee that Dawn is sort of heading up with a bunch of people here, some of us on the call. So yeah, so that kind of covers the supported housing beds.
Okay, great.
Yep.
We do have another question from someone who she asked the question and then said she had to drop off for another meeting. So I'll have to give her whatever your answers are to it later on. But the question is, are there any plans within the counties to work with primary care provider offices to expand provider capabilities to provide office-based SUD services within the primary care settings? And that is directed at any one of the three of you.
So this is Pat from Lewis, and at this point in time, there's no formal plans. I can say that under DSRIP, there were some initial efforts to embed a peer into the primary care. That is no longer being done. I do know that some of the challenges to that were just simply space and workflow. So it was helpful. And ultimately, I think they chose to not actually be embedded there, that it was really going to be like in the traditional, the primary care calling and getting those appointments.
Thank you, Pat. Anyone else, Tim or Jay?
Yeah, I think one of the limitations on that is that while a primary care physician can certainly work with their patients on medication assisted therapies, they're really not positioned in the workflow to provide the other part that's really important to addiction treatment, and that's the counseling therapy groups. So there's some limitations there. I do know that New York State is cautiously embracing teleservices in that realm. And we actually had a call a couple of weeks ago, the DCSs regarding that. Again, it brings everything that's new is always going to bring some concerns and some questions and figure out how to get over the obstacles. But I think there's a lot of innovative thought happening right now to expand services, and I don't think anything's off the table currently.
Okay.
In St. Lawrence County, we had Dr. Updike come from Buffalo. the Catholic hospital system in Buffalo, and he has runs three OTP clinics, rather large OTP clinics, and he's really an expert in his field. And he's come up a couple of times, and he's done some data waiver trainings for some primary care. I know a lot of the St. Lawrence Health System's emergency room doctors became data waived, so that if someone comes into their emergency room, they can also prescribe medicated assisted treatment. In terms of the number of the primary care folks that underwent and got the data waiver from Dr. Updike, I really don't have any numbers or statistics in terms of how many people they're actually serving. But I do agree with Tim. I mean, there is the ancillary supports of counseling and group that are also important for people in their recovery. So.
There's been somewhat of a push to allow folks, if they don't want counseling and they just want medication. Again, I've heard this here and there, and I was wondering what your take is on that. Do you think that counseling is a necessary component that has to be in addition to medication-assisted treatment?
Well, really, OASIS went to a harm reduction model. And really what that means is that even if somebody, let me back up. In the past, if someone came in for addiction treatment services, we had a treatment plan and so forth, they did not, quote unquote, comply, and they tested positive for, different, street drugs or whatnot. There were times that we would recommend inpatient services, inpatient rehabilitation, and then if they did not choose to do that, then oftentimes those individuals were discharged from treatment. So it really doesn't in looking back, it really didn't make a whole lot of sense. So now, with the harm reduction model, if someone comes in for treatment for, say, opioid use disorder, and they really don't want to participate in counseling or group work, we continue to provide that medication because the risk of overdose, particularly with opioids, is so high that, in this way, at least they are getting the medication to curb their cravings so they don't go out and use the street drugs, heroin, fentanyl, or whatever. So it's been a radical shift, in that philosophy from OASIS over the past several years. So yes, we continue to provide, whether it's, Suboxone, Subutex, Vivitrol, and now, at the county level, methadone, in spite of, they're not willing to participate in treatment. Actually, I take that back. With the methadone program, it's a little stricter in terms of their obligation to continue being engaged in counseling and group services.
Okay, thanks, Jay. So you mentioned Vivitrol, and I think Tim and maybe all of you spoke about MAT services in the jail and the mandate. That's was it October is when that is coming in. So is Vivitrol, because I know one is, again, I don't know everything about this, so forgive me if I'm saying these things wrong, but I think Vivitrol is an antagonist. Is that what it's called? Where another one is an agonist or a partial agonist. Vivitrol does one thing. I think it stops the high from occurring, where the others do something a little bit differently. Does MA, if a jail wanted to just do Vivitrol, let's say, is that checking the box for providing MAT in the jail, or do they have to also provide Suboxone, methadone, and other medications?
All of them.
That they do.
Yeah. The legislation is pretty comprehensive, and it requires that the jail requires multiple choices for the inmates or incarcerated persons.
Okay, thank you. I think Ray Babowitz has a question.
Not so much a question, just a statement back on the question on behavioral health care and substance use services in a primary care office. And I obviously can't speak to it from an individual primary care physician's office, but from us as a federally qualified health center. Pat, I think you are aware there's been certainly success and positive movement in integrating the behavioral health piece into the primary care environment. I think specifically at the federally qualified health center arena. And of course, that can alleviate pressure back on county run services and everybody wins. But we need to remember besides the workforce challenge, which is just killing us, there's a lot of regulation on the books that really kind of dampens how much anybody who's in Article 28 space can do. You know, from the way your facility has to be set up from a waiting area and entrance perspective to what percentage of patient panel can only be seen for behavioral health. There's a lot of things, and maybe even furthermore back in the workforce challenge, there's many designations of behavioral health workforce positions we're not even allowed to bill for, even though you can bill for them in an Article 31 setting. So if they're good enough to be billed in an Article 31, why are they not in the 28? So there's a number of things we need to overcome at a regulatory level to further enhance the integration of behavioral health in the primary care setting. Hopefully that all made sense. So sorry, not so much a question, but just a clarification.
No, appreciate that, Ray. Thank you very much. Does anyone have anything to add to that?
Better.
No, it's like a whole full-time like job and field to figure out how to make all the regs work together when you try to share or combine services. Ray makes a fantastic point.
Anyone else have questions? All right, we have one here that says, everyone has referenced concerns with staffing or workforce concerns. Has it been difficult for citizens advocates to staff their behavioral health urgent care, for them to staff their center? And if not, is there any insight that we could glean from them on their strategies to hire qualified staff?
Well, it's my understanding that they currently have 4 licensed clinicians at the behavioral health unit. You know, I'm not sure about some of their other ancillary staff. I do know they have peers, care coordinators. They have some psychosocial rehabilitation specialists. Whether they're fully staffed in those areas, I'm not 100% sure right now. I do know that Citizen Advocates does use a recruitment company. I'm assuming that that's probably just not limited to, you know, looking in the North Country area, but it's probably state and maybe even nationwide. But I'm not exactly sure what the name of that company is.
Okay.
It's an important question because one of the fears anytime a new provider comes into a community is, where are the staff going to come from?
Right.
Anytime you add a service, anytime you add a program, that's the first question. Am I going to lose my staff to that program? And whether it's Citizen Advocates or one of our already existing providers expanding, we have to figure that out. Citizen Advocates does have a very robust recruiting strategy. I think they use a number of recruiting agencies. I will say, however, they've been very open about their strategies and collaborative with a lot of the providers here that they're not going to actively recruit from those providers. So it's, you know, it's a real balancing act for all of us to expand in a way that is sustainable from a workforce perspective. And that sometimes does slow down the work.
Yeah. Okay, thanks, Tim. So it looks like we're running out of time here. So I'd like to just conclude by thanking the United Way North Star team, Dawn, Tanya, and Allison. Thank you so much for putting this event together. we're really fortunate to have a professional development center like this that helps us communicate and collaborate with each other. So this was great. A special thank you to our subject matter experts for today, our panelists, just not only for sharing their insights and answering our questions, but really for the work you do each and every day to ensure your county residents have access to the needed services. And lastly, thanks to all of you who participated in the event today, especially those who asked questions. I'm sure you'd all agree that the information that we shared today and that our panelists shared today has given us really great insight into the services and resources that are currently available, but also the challenges that we face going forward too. But more importantly, as Dawn mentioned at the beginning, we hope this event really has opened the door for continued discussions on these things, for new opportunities, for future collaborations where you can learn from one another, where we can identify opportunities for improvement and continue to provide the North Country residents with the services and supports they need. So I will end with that and hand it off to Tanya.
Thank you, Pat. And thank you, Pat, for moderating and keeping us on point today and really hitting a couple of high points. I just want to reinforce Pat said, if there's anything that you heard today that you'd like to go deeper on, that you'd like us to introduce content on, please put it in the chat or respond to the email that you'll get from us. I've been putting in the chat our survey. We want to hear your feedback on the session today and future topics based on what we heard today or different topics. There's also a home base with the slides and where the recording will be that we'll share out with all participants as well. And we appreciate you all joining us. And to echo what Pat said, thank you to our subject matter experts for committing not only the time today, all the prep time so that we got all our logistics together, and Dawn for opening us up. And we hope you all have a great day. Take care. See you soon.
Bye.